Afternoon and welcome to the show. I'm Jim Flyzik. Today's show, we will discuss critical issues facing government and industry leaders and using information technology to improve healthcare and healthcare services. With me on the show are Dave Bowen, the Chief Information Officer at the Military Health System, Dr. Doug Fridsma, the Chief Science Officer and Director of Science and Technology, Office of the National Coordinator for Health Information Technology, Chuck Hume, the Deputy Chief Officer for Health Systems, Veterans Health Administration at the VA, Sanjay, Joshi, the CTO, Life Sciences, EMC, Isilon, and Ken Kartsen, the VP Federal at McAfee. Let's talk a little bit about, let's first get to know each of you and what your role is in the health IT issues, and maybe about some of the progress you see being made during the past year in your agency. Let's start with Dave Bowen over at Military Health Systems. Dave, what's your role and where do you see some progress going on over at your agency?
Well, good afternoon, Jim. It's a pleasure to be here. My role at the Military Health System is basically threefold. One is I oversee the information technology that's in place all across the military health system, a network of 57 hospitals and over 500 clinics worldwide. Second part of it is to oversee the IT that supports our TRICARE military health plan for our retirees and service beneficiaries. And then the third part of my job is to work collectively with the VA to implement an electronic health record system for both organizations, and I'm sure we'll talk about that a little bit later on. I just joined the agency in September, so I can only report on the progress since then, but I can tell you that certainly on the electronic health record front with the VA, we've made some significant progress. We're also involved heavily with the VA in sharing data, getting them data that they need to more effectively work with our military members as they transition from the DoD into the care umbrella, basically, of the Veterans Administration. Right. So that's kind of what I do. Yeah, boy,
that's a lot of complexities there, I'm sure. And one thing about health IT, there's a lot of debate about health policy and things like that going on, but I think everyone is in agreement that if we can use technology to reduce health cost and to improve health services, it's sort of like everyone's for that. So, Dr. Fridsma, Doug, how about over in HHS at the National Coordinator's Office there? What's your role and where do you see progress being made?
So I'm the Chief Science Officer. I direct the Office of Science and Technology, and so our portfolio of work includes identifying and harmonizing the national standards for health information exchange, managing a portfolio of standards and trying to assist folks who are trying to implement those and use them within their information technology. We have an innovation portfolio that tries to look at new ideas and make sure that the innovation community is at the table and can participate in health information exchange. And we also work on the federal health architecture. So that's with a series of our federal partners, the VA, DoD, SSA, CMS, to make sure that the federal government also has the standards and the kinds of tools that they need to be successful.
Yeah, terrific. There's a lot of that information sharing going on. I think, tight budgets and all are forcing people to find ways to share things and learn from one another. Sanjay, how about over at EMC? What are some of the areas that you're involved in and where you see progress being made to perhaps help some of your government customers move forward?
Good afternoon, Jim, and happy spring. I tell people I stand on a stack of soap boxes with a periscope and looking over the future fence, if you will. Really, I'm a field-based technologist, and I get my role is to get feedback from the customer base. I travel quite a bit and look at the convergence of multiple technologies like genomics, digital pathology, vendor-neutral radiological archives, and mobile health. Then I try to find the patterns in the convergence and how information technologies can actually improve the care and health of patients. But the first question I usually get asked is, where do I put all this stuff? There's a deluge of data coming. EMC has always done well in research genomics, healthcare systems in general. We are, however, gaining traction in what we call scale-out storage. storage that's in the petabyte and exabyte scale,
Right.
which I'll talk about later.
Right.
And we're making inroads into digital pathology and clinical genomics.
Yeah, I'm sure the big data trend is going to impact healthcare quite a bit too, in terms of using information and manipulating business analytics to.
Correct.
Chuck Hume, welcome back to the show. How about over the VA? What's going on over there? What's some progress you see being made in your area?
Well, good afternoon, Jim. So within the Department of Veterans Affairs, I reside, come from the Veterans Health Administration. And I think as many of you know, within the Department of Veterans Affairs, we've consolidated all of our IT organization at the department level. So my role is the primary interface between the Veterans Health Administration and our centralized IT organization. Lots of progress in the last year. VA's, starting out as one of the most integrated, wired integrated healthcare delivery systems in the world. And so, stepping off from that background, a lot of progress in the last year in continuing to improve the integration or interaction with our veterans in making more of their healthcare information accessible to them through Blue Button and My Healthy Vet. We've transitioned our healthcare delivery system to patient-aligned care teams and building a health management platform around that new entity within the healthcare delivery system that integrates the patient with their healthcare delivery team. A lot of activity going on now with mobile apps. There's an app for that kind of a atmosphere in the VA, and we're building an app for that, whatever that is. And data standardization is huge. That feeds right into our work with the Department of Defense in the data exchange and data interoperability and the integrated electronic health records.
Yeah,
so
that transition of the records from DoD to the VA. And I'll tell you, no matter what topic we have a radio show on, mobility finds its way into the discussion somewhere along the way. There's just so much going on in the mobility world. Ken Kartsen over at McAfee, what are some of the areas that you're working in related to health IT, and how are you positioning to help perhaps your customers move forward?
Yeah, thank you, Jim. Much of the way we look at the world from a health IT perspective, we take a holistic view of security in general and try to apply those capabilities that we have as a security company and integrate those with things that the health IT industry is trying to accomplish, whether that be improving doctor-patient relationships and leveraging systems that are in place today. Mobility has been brought up as a big one. How do you apply security around mobility and health information records and privacy information and patient information? And trying to take those capabilities, whether it's encryption, data in motion, data in rest, mobile security, all the types of things you would generally think about from a security perspective, but apply them to the health IT vertical in a way that's applicable to the services that are trying to be leveraged.
Yeah, well said, and hopefully we'll have a little bit of time to talk a little bit more about security and privacy, because I think that's always a concern with health records. Let's talk a little bit about areas of opportunity. Where are some of the real core areas where we think we can make a big... Let's start with Chuck Hume this time. Chuck, how about where do you see some areas moving forward here where there's some big opportunities to use technology to really make some improvements?
So I think where we're focused, major focus, is on making the veteran more a part of their care delivery team. And information is a key component of that. I think historically we've maintained paper and electronic health records as an institutional record. We at the VA really believe that record belongs to the veteran, and they need to have immediate access to all the information that we have on them. It's their record. It belongs to them. So over the last year, we've really focused our attention on a Blue Button initiative to make, through My Healthy Vet, a veteran can access essentially all of the electronic health record information that we have on them, and since January, with open notes, they've been able to access even the provider notes in text form. We've always provided that to them, in paper form if they ask for it, but I think now we're able to provide that to them in electronic form. I talked about mobile apps. I think that's the major focus area. That's the future of automation, the platform for both veterans and for providers is going to be a mobile device, and so we're building applications that will support that environment.
Yeah, terrific. I like that focus on individuals taking control. I remember some of the debates way back when about, should there be some type of health card or whatever, and then people say, oh, we have privacy issues and this. But then I'd say, who knows where their health records are today? I mean, short of someone maybe who had an entire career in the military or something like that, most individuals have no idea where their health records exist today. So by getting them in a format where, you know where they are, makes a big, big difference. Dave Bowen, what do you think? What are some area opportunities that you think are key opportunities that we can take advantage of to really make some improvements?
Well, Jim, as some of my staff say, it's all about the data, and I think that's really true. I think we do a great job of collecting data, but we collect it in so many silos that it's tough to move around, and it's tough for our physicians to get a complete picture of what kind of care the patients received, what the patient's history is, et cetera. I think within the DoD network, we do a superb job of moving data around. We can have a serviceman seen at a clinic in Italy, 2 days later fly into Jacksonville or Bethesda, and all those records are there. So that's a great area of strength for us. When the service people go outside of our direct care network and they go into TRICARE and they see a commercial provider, we don't do such a good job. Right. It's tough to get that information back. I can tell you, we were talking about aging a little bit before the show.
You have to bring that up, Dave.
I've had a string of unfortunate medical incidents, and I've seen in the last 3 or 4 months, I've seen my GP, been seen by an orthopedic surgeon, and I've been seen by a gastroenterologist. They're all in the same campus, the same hospital.
Like, and you filled the forms out every single time, I bet.
Exactly. Do you think that they can see, my information from each other's visits? And the answer is no. So certainly we're working much more aggressively to try to integrate all of that data. And so that we don't have the necessity of repeat tests when our members basically transition from provider to provider. I think Chuck talked about involving the patient more in the care. You see a lot of areas there. And then the other thing we're very aggressively working on and have been in the military system is how do we detect and promulgate clinical best practices, whether it's a serviceman injured, out in the theater, or whether it's care of a serviceman's wife, OB, or something like that. We're constantly, and our docs are constantly looking at what sort of clinical results, what can we do to improve our clinical results, and what practices sort of contribute to that, and basically to find that out, again, it's all about the data.
Yeah, it really is. It makes a lot of sense too. If someone has some unique kind of an issue, if you can find access to someone else who's treated someone with that unique issue, make a big difference. Yep. Doug Fridsma, I've been over at the National Coordinator's Office, HHS. What are some areas of opportunity that you think are really key to moving forward and making a big difference?
Well, I think if you're going to be able to use data, you have to make it electronic first. And so in 2008, we had 17% of all practices that actually used electronic health records. Through the Meaningful Use program, by 2012, we have 64% adoption, and we expect by 2015 to have over 85% of electronic health record adoption in this country.
Wow.
That is, 1/6 of the GDP, changing dramatically in the course of 7 to 8 years.
Wow.
So that sets the stage, I think, for ongoing opportunities. We have now established a national standard for how transitions between different care settings can exchange information in a standardized way. We've recognized 4 major vocabularies for how we code our information. And we've also provided a standard way to exchange between electronic health records. So the building blocks are there now. I think once we have those building blocks in place, there's 3 things that we can do.
Okay.
I think we first have to measure what we do, because if you can't measure it, you can't improve it.
Okay.
And so quality assessment is an important part. The second thing we have to do is we have to learn from what we do. And so we have to identify what the best practices are, and we have to figure out how to apply that to the work we do. And then the third thing is that once we've measured and we've learned, we need to improve what we do. And that has to do with clinical decision support, integration in the workflow, and making sure that the health information system is a real partner in how we take care of patients.
Wow, terrific. So that day of actually going from office to office to office and having my records go with me is getting there. If we get everything in electronic form and we've got mobility like Chuck talked about, then we have the ability to move records along with us. That's it'd be exciting. Ken Kartsen, what do you think are some of the big areas of opportunity to really make differences here?
I think one of the largest opportunities we have is actually to lower healthcare costs over long-term periods of time.
I guess that's sort of like the intuitively obvious one is that's important to do, isn't it?
Yeah, I mean, we can leverage all these technology platforms that we're talking about, whether it's the big data or the mobile applications, and obviously put security around that and make sure that our health patient records are secure and more accessible, and there's shorter doctor lines, even if those lines may not be a line. You may be at home getting your service. If we can leverage those future capabilities, we can certainly lower the costs associated with healthcare and dramatically change the perspective of healthcare in this country.
Oh, terrific, terrific. Sanjay, I'll bet over EMC. What do you see as some of the big opportunity areas?
So Jim, let me take a more horizon view of this.
Okay.
And I'll try and divide my answer in three parts: patients, electronic health records, and storage, which is what EMC does.
Right.
Firstly, I think we need to pay more attention to early detection technologies, so to transition from where they are today, which is in academic research, to more a clinical approach where you actually try and understand from a larger population perspective where the world is going. For it to become statistically significant, I mean, we need to do a lot more of early detection. That actually bends the cost quite heavily as well. Secondly, I think we need a more concerted effort to increase the use, as Doug mentioned, and the analytics of EHRs. Even though I think there's some initial evidence that EHRs increase the rate of fraudulent use, I think in the long term, EHRs will greatly reduce the more than $750 billion in waste and fraud that is perpetrated on our healthcare system, not just the VA part or the government part, but generally healthcare in the United States as a whole. Finally, I think the issue of data custodian. When you generate all these large amounts of data, who is the custodian? Who manages all this data? And I think at some level, let's paint a picture. If every citizen in the United States had their whole genome sequenced, what would that data look like in terms of size? I mean, this is massive. I think it's about 8 football fields of spinning disks with about 10 stories high, just of disk drives.
Wow.
I mean, who pays for it? Who manages that kind of infrastructure? And, this isn't a petabyte and exabyte scale. You ask a question, what is a petabyte? So I have a USB drive here. If you put, this is a 1 gigabyte USB drive. I'm sure every one of you guys have this in your keychain. If you take a 2,000 square foot house and stack this floor to ceiling, 10-foot ceiling, I guess, that would be a petabyte. An exabyte is 1,000 such houses. So, I mean, I would say looking forward, I wouldn't be surprised if a large enough hospital does 50 petabytes a year.
Wow.
I mean, this is the kind of data that we're trying to handle looking forward. I think from a federal and state perspective, the HIE, or the Health Information Exchange, has not been mentioned here. HIE is, I think, the hub to many healthcare spokes, EHRs, pharmacies, payers, labs, public health, and patients. So I think that's kind of a broader view of Horizon.
Yeah, things are happening quick. I look forward to a lot of these things come to fruition. I want to talk a little bit now about challenges and shift gears a little bit. But before we do that, we're going to take a short break. You're listening to the Federal Executive Forum on Federal News Radio, 1500 to the Federal Executive Forum on Federal News Radio, 1500 AM. I'm Jim Flyzik here with Dave Bowen from MHS, Dr. Doug Fridsma from HHS, Chuck Hume from Veterans Health Administration at VA, Sanjay Joshi from EMC Isilon, and Ken Kartsen from McAfee. We're talking health IT records. years. When we went to break, we were talking about progress and opportunities. Let's talk about challenges a little bit, some of the hard stuff, things that you got to, sort of like the hurdles we need to get over to get where we're trying to go. Let's start with Doug Fridsma over HHS. Doug, what are some of the real challenges yet that you feel like we have to get over before we're going to really get to where you want to go?
So we've made incredible progress, I think, in the last couple of years in getting adoption of electronic health records and getting data out of paper and into computer systems which we can then use. I think our upcoming challenges are going to be around interoperability. And I think it's going to be a challenge in terms of just the pace at which the change is occurring within the industry. With regard to interoperability is sort of two parts. It's exchange and use.
Okay.
And we've got the standards now to be able to exchange that information, but people are going to want to use that information in lots of different ways.
Yeah, right.
And I think as they find new ways to use it, we have to come up with new ways of representing and standardizing that information so that people can actually take the information and apply it to clinical decision support, quality improvement. I think timing is going to be a challenge. We are moving at such a rapid pace that people are really just trying to keep up. One of the biggest complaints is that government is moving way too fast when it comes to this. And that's a good thing, I think. But I do think that fundamentally, to keep everything running, we need to address the business models. There needs to be financial incentives for people to share information and to use that electronic information. And so I think big data analytics, I think ways of changing how we pay for care based on quality and performance are going to drive for more interoperability, better uses of that data, and improve patient care.
Wow, terrific. Well said. Yeah, I know there's even various doctors I see over time, there are various stages of going electronic. Some of them had never used computers before and things like that, so it's a big culture change for them too. Chuck, what do you see as some of the big challenges or things that you need to still overcome to get where you want to go?
So I know this will come to a complete surprise, but funding is always a challenge, right? We are a pretty connected healthcare organization, but I think that that kind of snowballs whenever, for every improvement we make in health IT, there's a dozen new, better ideas to capitalize on that. So increasing tension for funding within the IT budget for lots of great ideas, and then contention with the other things the department needs to do with its money in addition to IT, right? So that's a challenge. I think another area is as we begin to assemble the more comprehensive record of information that an individual has among multiple settings, identity correlation is becoming a huge challenge. We're making good progress in that, but there's just no single identifier that you can use to collect all the information on a single individual. So making sure that you got all the information on the individual and only the information on that individual is a challenge. Sanjay talked about huge data. We're collecting more of the information as we assemble a complete record, and you throw in things like genomics, and you've got a lot of information on an individual. When the person shows up, when the veteran shows up to their provider, that poor provider needs to be able to consume that, and do it within the time constraints of a visit. And so, building more intelligent systems that support the provider, that assemble just the information they need for that encounter and for that specialty and for that veteran and that veteran's problem they're coming in for. Smarter systems are a challenge that we need to overcome.
Yeah, well done. And that identity thing too, I've said many times on different topics, if we can just get that identity management piece down, it will make a lot of other things start falling in place. Dave Bowen, how about at MHS? What are some of the challenges that you face that you're still trying to get over in order to get where you want to go?
Well, I think some of our other panelists talked on it. I get very interested in the challenge of change and change management. I have a saying that, in our business, the silicon-based units are easy to manage. It's the carbon-based units that are difficult. And certainly the culture of change and change management, getting our physicians to do things different ways, bringing best practices into the organization and driving them down through the organization, certainly a challenge that we will face over the next couple of years that's pretty significant. Again, I'll go back to the sort of the information integration, interoperability comments that were made earlier. And then finally, we talked about identity, but one of the big challenges going forward is as this information promulgates itself out to more and more locations, and that's a security issue.
Sure.
How do we keep all this
Absolutely.
stuff secure and still be able to give the people who need to have the access to the information that access?
Yeah. If we have time today, we'll try to talk a little bit more about just that because it is a big deal. Ken Kartsen, what do you think in terms of challenges? What are some of the big challenges you face in trying to move forward with these programs?
Thank you, Jim. I think secure integration and interoperability is probably the largest, not because of just all the applications we're starting to build today to prepare for all the medical health records, but all the ones that have been built over time. Every time we go to the doctor, they seem to have some information about us, whether it's a new doctor at a hospital that we've been to before or our general practitioner. Taking all that data and slowly integrating it together to have a common picture is a huge effort.
Right.
There's information about us all over the place at all types of different medical facilities and doctors' offices. And then once we do apply that and we do have interoperability and we have all that data together, it really comes down to identity and access management. Who should have access to it and what parts of it should we have access to, and applying that information and identity access to it. That's going to be a huge effort to help secure that and make sure that the right people have access to our information.
Yeah, good. Yeah, but I'm going to talk a little bit more about that too, so we'll get your thoughts, a little deeper thoughts on that same subject here in a few minutes. Sanjay, the obvious one that I can see already is this massive amounts of data that needs to be stored. But what else would you look at as big challenges?
Let me try and integrate all the comments that were here. I've heard this many times. Many wise people have mentioned this. I think the saying is big data without big integration equals big confusion.
Right.
So, and I mentioned health information exchanges like Health E-Way, which was actually a government project. I mean, Doug mentioned the government's actually moving faster than everybody else. And HITRUST, which was a White House and HHS and industry effort for security, for better data interoperability and better frameworks for security. I think, in my opinion, it is a scalability, of course, from a volume perspective. It's speed. Is interoperability and security. I mean, there's in very large, broad brush challenges. That means rethinking EHR infrastructures for the mobile and device age. I mean, we didn't mention wearable devices and silicon dust and where information is gathered on a real-time basis for a long time. And also rethinking protocols like HL7 and DICOM for the web service age, where things are moving fairly quickly. And finally, as Ken mentioned, rethinking security infrastructures for an industry that's fairly slowly ramping up toward the challenges. Cybersecurity is one of those issues. So.
Right. Well, let's talk a little bit more about that security issue then. It's come up quite a bit here in the conversations. What are some measures you're taking to make sure that security is built in and the privacy of individuals' records are being maintained? Let's start with Dave Bowen at MHS. Dave, what are some of the things you're doing to address those concerns, to make sure they're addressed up front?
Well, this is a problem we think about and work on almost every day. Certainly, one way of dealing with it is to make sure that the data is encrypted, and so we're looking at encrypting the data both in motion and at rest.
Yes.
That's sort of a fundamental area of activity. The other thing that we're working on is, as we talked about identity, not necessarily the identity of the patient, but the identity of the caregiver, and how do we make sure that the data is going to the right person?
Right.
So certainly across the MHS, we're working on extending sort of the CAC card methodology used by the military to our caregivers so they can transition amongst facilities and not have to recertify and do all that stuff. And certainly then through efforts with the VA, extending that methodology over to the VA so that our patients can seamlessly transition to the VA, and our providers in the MHS can talk to the VA providers as necessary. So those are some of the things we're doing right now, but it's an ongoing challenge.
Yeah, well, I think we've learned sometimes the hard way that we can't be reactive. We have to be proactive. You got to get in front of this issue, because I remember back when I was in government and I was at OMB one day, there was a board with a long list of programs that had failed because of making mistakes with privacy and security. And then, all it takes is one big mistake that goes out publicly, and it can bring a program to a halt awfully quick.
I can tell you from experience, a privacy breach is a very unpleasant experience.
Absolutely. Chuck Hume, what do you think? And how are you addressing those concerns about privacy and security, which I'm sure come up with just about every conversation around moving forward?
Right. So our chief of cybersecurity likes to say that information security should be a speed bump, not a roadblock.
Okay.
And so it's making sure that we've kind of balanced the tension between access to information, secure access to information, versus ultimate lockdown security.
Right.
So it's finding the right balance there and putting the right controls in place. We're kind of on the leading edge of exchange of information, not just with DoD, but with private sector and with veterans. And we're working close with Doug and HHS on kind of establishing what are the right security standards to put in place in those information exchanges, since we're really kind of among the first organizations to participate in that exchange. And on the privacy side, we got to recognize the desires of the veteran.
Right.
They may or may not want information shared with certain certain others, and so we've got to kind of tailor that configurable privacy controls around. The veteran wants this kind of information shared with these kinds of providers,
Sure.
and not this other kind of information. So it's getting that more granular privacy controls in place.
Right.
That's the real challenge.
Right, good points. And you brought that up earlier when you're talking about, personalizing this, and that's back to where if you can get that identity, the authentication piece and the identity piece down, then a lot of these other decisions could be opt-in decisions that are up to the patients themselves.
Exactly.
Some patients may have different attitudes about what's shared and not shared. And as long as you can get the core information exchanges that are necessary and the identity and authentication correct, then a lot of optional things, I'm sure, can grow off of that. Doug, what do you think are some of the big challenges yet in security and privacy? How are you addressing those in the work you're doing?
Well, we like to say that information moves at the speed of trust.
Okay.
And so what that means is it's vitally important.
I like that. That's good comment.
We make sure that the data is private and secure. So as part of our certification program, we require all of the electronic health records to use state-of-the-art certificates and security to make sure that they're authenticated and encrypted. Excuse me. We require for the incentive program that everyone do a risk assessment and make sure that that's accessible so that people have thought through those security issues. And we're trying to look ahead as well. And so the notion of taking data and getting more granular protections on it, we've actually done a series of pilots and established a set of standards that right now are going through the process of balloting and being approved, that allows an individual patient to segment their data and share certain portions of the data and not share other portions of the data, empowering that patient to be able to have that more granular control.
Yeah, it's back to that like opt-in kind of an approach. Yeah, well said. And Chuck's comment there about the speed bump there, I remember that we had having security officers say, we can't do that. And my answer would always be, yes, we can do that. Your job is to figure out how we can do that. That's what your job is, not saying we can't do that. Sanjay, what do you think are some of the security and privacy steps that need to be put in place, and how are you guys addressing them over at EMC?
Yeah. So I'll use the two C words. One is cybersecurity, the other one is cloud. So after a year-long examination of cybersecurity, I think the Washington Post declared a couple of months ago that healthcare industry is the least prepared of all industries in the United States to bolster its security infrastructure. as it moves to this digital, mobile, and device-centric age. I think in a non-healthcare world, you see this movement to a public cloud already happening, the race to zero cost, IT infrastructure, and so forth. I think for healthcare, I did mention HITRUST already, which was a public-private initiative. What is very interesting is, according to the Department of Civil Rights, which is actually, I think, an offshoot of the HHS, there have been 21 million security breaches in healthcare in about an 18-month period.
Wow.
50% of those are usually lost tapes and lost laptops or whatnot. But I think as we kind of move into this space, we at EMC have been looking at, for example, self-encrypting drives, so that when data comes in, data at rest is already encrypted, so you don't have to worry about key management and some other features. I will also say that one of our cousin companies at EMC is RSA, and we've kind of been thinking about this issue for a little while. So we're trying to integrate from a big tent perspective what that means in healthcare.
Yeah, terrific. Well said. Ken, I purposely waited for you to be the last speaker here, because when I think of McAfee, I think privacy and security and being a core feature of the company itself. So how are you looking at addressing privacy and security and helping your customers make sure that their data is secured as they move forward with these programs?
Sure, and I'm glad our marketing is effective. So we kind of look at the world holistically from a security perspective. We talk about all these different things, the big data, the data centers, cloud computing, mobilization of IT, consumerization with all these mobile devices. We have traditional endpoints. When we apply that to the health IT sector and think about all the health records, the privacy information, how that data is moving, no matter what it is, whether it's data at rest, data at motion, the network segments that we're trying to protect from attack, the endpoints that we don't want to be compromised with any vulnerabilities that may exist. It really comes down to the different types of protection that you traditionally put on these systems, whether it's silicon, whether it's what type of silicon it is, whether it's the information itself or it's the device itself. How you apply that security and how it all integrates together into one common platform as seamlessly as possible, leveraging a lot of the new capabilities out there in security, and also integrating all those investments you've already made in your security infrastructure and trying to bring that together into one common platform.
Yeah, I know we've done a number of shows on cybersecurity itself, and the complexities around the issue are tremendous, and just defining all the moving parts that are in networks today. And there's a lot of push on now for continuous monitoring tools and things along those lines. I want to talk a little bit about coordination. And it seems to me, with these things we're talking about, there's so many players out there. We've got the private sector, we have insurance providers, we have private practices, we've got hospitals, we've got VA hospitals, we've got government programs and so forth. I'm interested in hearing the perspective on how we go about trying to coordinate all that. But before we get into that issue, we're going to take a short break. You're listening to the Federal Executive Forum on Federal News Radio, 1500 AM. Difficult. Turns out to be a lot more complex. Chuck, Hume, what do you think? What are some of the ways you're trying to reach out to make sure you involve all the relevant stakeholders in this process?
Right. I think, years ago, 15 plus years ago, when we started doing a lot of data exchange with the Department of Defense, it was just hard. Right. But two organizations, we could establish what the standard was between, just a two-party agreement, and that was the way we were going to exchange information. Well, we're now, the brave new world of trying to exchange that with all of the private sector providers who deliver care to veterans and service members. Now it's really hard. And, thanks to the leadership of HHS, we're beginning to, and working closely together with HHS, VA, and DoD, and HHS, and private partners are coming up with national standards for the exchange of information. We're making big progress in that. The virtual lifetime electronic record that the President announced several years ago, we've made substantial progress on that. We've got 13 VA medical centers now engaged in e-connected health. With about the same number of private sector partners and a lot of engagement with the Department of Defense in that too. And so So we're overcoming those obstacles, but it is a lot of negotiation and coming up with what could be the standard that everybody can agree to, not just the two-party agreement that we had with DoD.
Sure. Dr. Fridsma, I purposely left for you to be the last one because it seems to me that the role of the national coordinator here is to do just that, figure out the word itself, coordinator. I mean, it's kind of your core responsibility, I guess, to figure out how do we coordinate all this stuff. So how are you taking on that task?
So it's a big task, and I think we've got a number of programs in place that we hope will help improve coordination. Under the Office of the National Coordinator, we have the Federal Health Architecture, which is really a mechanism to bring together VA, DoD, and a variety of other agencies to try to identify how to exchange information and what are the standards that will support those agencies. I think we see our role as best described as government as a platform. So we've established what we call our standards and interoperability framework. It's a way of convening people who have common problems to come up with solutions that they all can agree upon. And that was a way of accelerating the standards process and engaging both the private sector and the public sector together to come up with standards. And that's been a very, very successful model going forward. We also have what we call our implementation and testing platform. Again, as people are using these standards, we're going to find problems. We're going to find interoperability challenges. And if we have a rapid response and ability to support and address those concerns, I think we can make more rapid progress. But I think what's important to recognize is we don't see our role as building the system. The VA and the DoD, they're going to build their systems. Our role as the national coordinator is to worry about the interstitial spaces, the spaces between the systems, to make sure that we've got the right standards, we've got the right services, we've got the right ways of transporting securely information between them, and that to use open, transparent, and sort of publicly accessible ways of reaching consensus, because then the solution isn't something that government has identified, it's something that the community has agreed is the right path forward.
Terrific. So you're kind of like doing the steering, but others will do the rowing in terms of getting it done. Very good. We're down to just under 12 minutes left to go in the show, and like we always do, we like to kind of get your thoughts on where this is all going. What's the future look like here? What do you see as a vision for using information technology in the future? What will the world look like because of these efforts that are going on? Let's start with Ken Kartsen at McAfee. Ken, what's your vision for the future look like? Where's this all going?
Thanks, Jim. When you look at the health IT sector and trying to get to the places we want to get to and making it more efficient, and easier for the patient to get access to health care, making it easier to diagnose and treat for the doctors, making the diagnosis more accurate, making the treatment more proficient, driving down costs is always an important factor there, as well as securing everything that we're doing in the mix there, especially from a McAfee perspective. And I kind of get my sci-fi vision of how that all comes together. We think about all those TV shows and movies we watched where a doctor scans the patient with a little device and they know what's wrong and they apply the fix. Well, maybe that's not too far off. Maybe there is a device in the future that does a lot of that, and maybe it's a or some sort of vision of telemedicine, where there's a device in your home and you are in contact with your doctor over the internet, securely, of course, and encrypted as that data moves in motion.
Of course.
And you have that capability to scan the patient, the doctor sees the information and can apply the next steps in treatment. So that's what I would want to see as a vision for the future in health IT.
Yeah, well, we got virtual physicals now, I guess, and things like that. So we're moving in that direction. Chuck Hume, VA, what do you see? Where's this all going? What's your vision for the future look like? What's that crystal ball say?
Right. So I guess what I would say is kind of a recap of what I've been saying.
Okay.
First of all, I really see this kind of in three parts. It's first the veteran. The veteran is fully informed, fully engaged, partner in their healthcare delivery, part of the team that delivers care to them, that keeps them healthy, with secure messaging, exchange of information, easy exchange of information between the veteran and their provider team. The integration of that team and the integration of that team with a comprehensive healthcare record, that spans all of the care that the veteran has had, whether it's their time in the Department of Defense, the care that they receive in the private sector, the ability to integrate all that information and present it in such a way that it can be consumed by the care team and they can make the right decisions regarding that care. And then finally, we are amassing a huge amount of information on millions of patients, and that data presents an opportunity to mine it for population health and better understanding disease patterns and how treatment patterns affect those diseases across a huge population. And we can do amazing research with that amount of healthcare data on that many
Yeah, that's
patients.
well said, and that's a great point, what it's all about, better health in the future. Sanjay, Joshi, how about your vision for the future? What do you see down the road? Where's this all going?
Actually, following Ken's comment, the Star Trek tricorder is actually fairly close to reality. It's called the T wave, the Tom, T as in Tom, and it uses near field imaging. Excuse me. So
take a pill, like a smart pill,
that's
that
actually
goes through your body
reality
and figures
today.
out all the things wrong with you.
So if I were to stand on my stack of soapboxes, like I mentioned in the beginning, look with my timed periscope, if you will, I can boldly hope that primary care as we know it will disappear in 15 years.
Okay.
Why? Because of multiple early detection technologies, precision medicine, and some other things coming down the pike, genomics and proteomics. I also sincerely hope that in that same time period, we will reduce the complexity of our multiple healthcare models in our great country, both on the payer side and on the delivery side. And I hope this stack of soapboxes is distributed evenly to host the vast amount of information that we'll be creating. I quote Jim Gray, who he's one of the inventors of SQL Warehouse, by the way. He said, like astronomy, biological data has no limit and it requires data scale out, where the application needs to be very close to the data. The only difference is that there's a lot of money associated with biology. So, and I hope that we can reach for the stars and make America a more healthier nation.
Terrific. Yeah, I hope we do it quick, because as Dave reminded me earlier, we're getting a little older here these days. But Dr. Fridsma, Doug, what do you think? What's it look like down the road? What's the future have for us?
Well, I think it's hard to predict the future. Who knew that 5 years ago that we would have to summarize our life experiences in 140 characters and share them with the world?
That's a good point.
So I think there's a lot of things that we don't know in the future. And so I look back to history to help us get a better sense for what the future might hold. And if you look back at history, in 1906, between 1906 and 1912, there was a big revolution happening in healthcare. And in the Journal of the American Medical Association, there was a whole series of articles about a new technology that had come into healthcare. And it was called the physician's automobile. And there are probably 12 to 15 articles that are written in that time frame about the business value, about the technology, whether you should use solid tires or pneumatic tires, whether a steam engine was better than an electric or a gas engine. And there was a tremendous amount of discussion about how the physician's automobile will change healthcare delivery.
Wow.
In 1912, Henry Ford released the Model T, and healthcare changed forever. Because it was no longer about the physician and the healthcare system.
Right.
It was all about the patient having mobility and access to care.
Wow.
So I don't know what the healthcare future holds, but I do know we're at an inflection point, and I expect that the conversations that we have 5 years from now are not going to be about the physician's electronic health record, but it's going to be about empowering patients to be active participants in their care.
That's excellent. Very good point. I like the way you teed that up with the references to the early years. Dave Bowen, what's your future look like for you, Dave, at MHS? Where's this all going?
Well, Jim,
how's the world going to change because of all these efforts going on?
Just so many things going on. Let me touch on some of them. Certainly the use of genomics to better detect, better deal with disease patterns, actually being able to tailor a pharmaceutical treatment to a patient's specific genetics is certainly something that's right out there on the horizon. We talk about clinical evolution in terms of best practices. I was just talking to a friend of mine the other day who's planning to have a knee replaced, and he's going to have it done on an outpatient basis. That's pretty remarkable.
Yeah, it is really amazing how far surgery has come.
Exactly.
Things that you'd be in the hospital for a week, you're now in and out the same day.
Yep. And I kind of see a convergence of IT and medical technology. I mean, it's becoming increasingly difficult to determine which is which. We just had a conversation yesterday about, in the military health system, what is IT? Is IT any device that's attached to the network? I mean, that could be a blood analyzer or, an MRI machine or whatever. So more and more, I think medical equipment is incorporating more and more information technology. Mobile and wireless. I mean, we talked a little bit about that, but certainly your comment about swallowing a pill that goes through your body, that's probably not too far away from reality. I mean, there's lots of nanotechnology stuff being developed to basically monitor all kinds of body systems and treat all kinds of medical conditions. Certainly the increased involvement of the patient, I think, is going to be important, as we've talked about a number of times here today, and have patients play a more active role in their medical care and understand more. That's going to be a real culture change for a lot of people, myself included, I think.
Sure, people don't like change. I think it was Bobby Kennedy said 1/3 of everybody's against everything all the time, no matter what it is.
And then finally, just doing some reading the other day about increased use of robotics in surgery and sort of more precise surgery with better clinical outcomes. Again, a lot of this is driven by IT, so it's going to be an exciting time. We're certainly can expect hopefully to live longer than we would have otherwise with all these improvements, and be in better health pretty much over the entire course of our lives.
Yeah, terrific. Well said. I like that. As I've been listening, I've been jotting down some notes here that jumped out at me. So let me try to do a little wrap up here. One thing we know is we're making a lot of progress. In fact, what I heard is we might be moving too fast in some cases, because things need to catch up. Harmonizing of information is very, very important to be able to share it. We got to figure out ways to harmonize, and the convergence is a big issue. Convergence of these of stuff. Opportunities to make records more focus on the actual patient, to make it more personal and put patients in more empowered to take care of their information. Opportunities for data movement and moving records around. If we get the records electronic, we can move them around. That'll open up tremendous opportunities for research and better health in the future. Reducing cost, of course, is a big opportunity here. The more automated we get, the better we do with making healthcare more affordable. Some big challenges out there yet. We still have interoperability issues. We've got massive amounts of data that we'll need to have big analytics and analytical tools to work through that. Funding will always be a challenge, and that coordination of the number of the complexities of the stakeholders and the fact there's so many is going to create coordination challenges. The future, we talk a lot about secure and mobile and better ways to use those types of things, and I think what I kind of pulled out from the future was it's all about better health, and everything going on here is going to turn into people living longer and living healthier lives in the future. I want to first thank all of our panelists for being here today, taking time from your busy schedules to be with us.